Hello friends, I am Dr. Vikas Jain, a surgical oncologist here, and I am the TUGS India coordinator from New Delhi. Let me introduce about the event today, which is based on complete capsule of pancreatic neuroendocrine tumor, which are going to discuss today with esteemed faculty from Indian chapter of IHPBA and various part of India, expert in field of pancreatic tumors. In TUGS India academic event, every month we used to choose some less discussed topics and very relevant topics for the surgeons with special interest in upper GI surgeries and hepatobiliary surgeries. We arranged this academic feast without any financial support or sponsors, and thanks to all the faculties and panelists and for their voluntary involvement without any such benefits. So to start with, I shall like to invite first of all my co-host, my team member, Dr. Saumil Vyas, who is a consultant and consultant in upper GI pancreaticobiliary surgeries and liver transplant surgeon in Sir H.N. Reliance Hospital, Mumbai, Dr. Saumil. And with that, I will also like to invite our panelists one by one. Our first panelist with me, I think he is not yet joined us, is Dr. Rudra Prasad Acharya. He is a surgical oncologist from Gurgaon, Haryana, with a special interest in GI oncology. Presently, he is working as Director of Surgical Oncology in Paras Hospital. He has organized many surgical workshops in ISO NetCon in 2021. Our another panelist is my friend, Dr. Krishnan Agarwal, who is a young dynamic consultant in nuclear medicine in Sterling Cancer Hospital, Ahmedabad. He has more than 50 national and international publications. Our third panelist is Dr. Pinky Thapar. He is another young dynamic lady surgeon and well-known GI surgeons in region of Thane, Maharashtra. She is a faculty in lab training courses at Amasi, IAGS, and CMAST as well. She has done best paper awards for laparoscopic adrenalectomy, cholecystectomy, and other various topics. She has been a speaker at International Laparoscopic Conference internationally as well. She is a co-author and co-editor in various textbooks related to laparoscopic surgeries. With that, with all the board of panelists, I would invite my first speakers, none other than Dr. Sanjay Govil, who is a senior faculty and the current chief of Indian chapter of IHPBA. And presently he is working as senior HPB and liver transplant surgeon in Apollo Hospital, Bangalore, who is going to present his first talk on overview of pancreatic neuroendocrine tumors from a surgeon's perspectives. Over to Dr. Govil, sir.
Thank you very much. I'll just share my screen. Is my screen visible? Hello?
Not yet, sir.
Is it not visible yet?
Not yet.
One second. Oh, okay. Now?
Now it is visible, yes.
Okay. So, good evening, everybody. And I'd like to first thank Dr. Saumil, and Dr. Vikas for this opportunity. This is the first time that I'm on this forum, and I look forward to participating and listening for others in the future. So today, the topic I've been given is overview of pancreatic neuroendocrine tumors, the surgical perspectives. So the first thing is for us to sort of get to know the beast a little bit. These pancreatic neuroendocrine tumors are a heterogeneous group of tumors, heterogeneous in terms of clinical presentation, in terms of histology, in terms of clinical behavior, and in terms of response to treatment. And we have a huge variety nowadays of treatment options. The most important characteristic of most of these tumors is that they are very indolent and slowly progressive. And therefore, one must be careful in how one deals with them because, even left without treatment, many of these patients survive for many, many years. So we need to make sure that our treatment is not worse than the disease. So the vast majority of these tumors are non-functioning tumors. They constitute about 2 to 5% of all pancreatic tumors. The vast majority of these tumors are non-functioning tumors. They may be single or they may be multiple. And because they are non-functioning, they often present late and with very little symptoms. Many of them are picked up incidentally, or the patients are nearly asymptomatic or have very minimal symptoms. But at diagnosis, these tumors are often already metastatic to the liver, the lymph nodes, and much less commonly the bone and peritoneum and other sites. So management of these tumors does involve dealing with these metastases quite frequently. A small proportion, somewhere around 10 to 20% usually, but some say up to 40% of these pancreatic neuroendocrine tumors can be functioning pancreatic neuroendocrine tumors. And that means that they secrete a hormone. And the common ones are insulinomas and gastrinomas, but we'll discuss that a little bit later. And the other feature of these tumors is that they are often a part of a syndrome, a germline mutation and a syndrome. And the common ones are the MEN1, in which you have hyperparathyroidism. I think I've written this wrong. Hyperparathyroidism and also pituitary tumors. There is von Hippel-Lindau syndrome, in which you can get cranial tumors, renal cell carcinomas, pheochromocytomas, and other similar tumors, neurofibromatosis, tuberous sclerosis, and other syndromes like that. So one needs to incorporate the syndromal aspects of these tumors into the management as well. Now, the most common, the best way to image these tumors is by a pancreas protocol CT. These tumors are typically very vascular on the arterial phase, as is shown in this picture. They retain some of their hypervascularity in the venous phase, although it may become a little bit less. However, as I mentioned earlier, that these tumors are heterogeneous, so they can also be cystic in nature or a mix of solid and cystic. And basically, one must suspect this tumor in any patient in whom you have a hyperdense, an arterial phase hyperdensity, a tumor with a hyperdensity in the arterial phase, because as we know, pancreatic adenocarcinoma, which is the commonest, is usually hypodense. These can sometimes be mistaken. The pancreas protocol CT is also reasonably good for picking up tumors in the metastasis in the liver. But one of the characteristics of these tumors is that the primary can be very small, may be missed or may not be visible, and it's the metastasis which which are dramatic and apparently seen. And sometimes people mistake these tumors for HCC, but it's important to remember that one of the ways to differentiate, of course, is the fact that the background liver is not cirrhotic, but also the fact that these tumors don't wash out completely in the portal venous phase. If there are liver metastases and one is considering surgery, then ideally one should get a hepatobiliary phase MR to accurately stage the tumors in the liver and plan treatment, especially if one is considering any surgical treatment on the basis of the MR. The SSTR PET, which is gallium-based DOTA-NOC or DOTA-TOC or DOTANATE scans, which have varying sensitive, attachments to two or three of the 5 somatostatin receptors, are necessary in the management of these patients to detect metastases. And also, the PET scan may sometimes identify tumors which have been missed on the primary tumor. Sometimes, as I mentioned, the secondary is very large and the primary is missed. On the PET scan, one may be able to identify the primary. And it also gives us an idea of the behavior of these tumors, because it's the gallium scans which are typically taken up by the lower grade tumors, and higher grade tumors typically are picked up on FDG PET scans. Now, I want to discuss about the role of EUS, because as we'll see, the biopsy and grading of these tumors is quite important. So EUS biopsy can be done. It is not necessary in every single case, but certainly if the diagnosis is unclear, or if one is dealing with an MEN syndrome, it may be for MEN, it's more to pick up the multiple tumors, because MEN is usually associated with multiple tumors. So these are situations where an EUS may be beneficial, with or without a biopsy or an FNAC. Ideally a biopsy, but that's often difficult, at least an FNAC to get the diagnosis. Now, this is a cartoon which I picked up, which I thought may be quite helpful for functional tumors. And basically what this says is that this big G here is where most of the gastrinomas are situated, which is in the gastrinoma triangle. Of course, many of them are in the majority of them are in the duodenum, but a significant proportion of them are located in the head of the pancreas. Somatostatinomas are most common in the uncinate process. Insulinomas can occur anywhere along the entire length of the pancreas. VIPomas are typically in the distal body and tail, and the last G stands for glucagonomas, which are most commonly in the tail of the gland. These functional tumors are usually very well differentiated, and insulinoma, more than 90% of them are benign. For the others, it's somewhere between 60 to 90% of them are malignant. So they can have a very variable course. Now, the decision on surgical resectability is based on multiple factors. The functionality of the tumor, we'll discuss each of these in detail. But if the tumor is functional and symptomatic, producing a hormonal syndrome, then it obviously needs treatment. And there's no doubt that I'd just like to preface this talk with the statement that whenever possible, for low-grade tumors at least, surgery is the treatment of choice. And obviously there are nuances to that, and we'll discuss it further. So the size, the differentiation or grade, the stage of the tumor, the location of the tumor, and the associated germline mutations all influence the management, the surgical management of these tumors. The tumor marker, which is most commonly used, there are multiple, but the most common is serum chromogranin A. It's fairly sensitive in that somewhere around 60 to 80% of these tumors patients will secrete serum chromogranin A will have an elevated serum chromogranin A, but it's not very specific at all, since very many other conditions can cause an elevated chromogranin level. So it may not be elevated in very small or very low grade tumors, and a whole host of conditions, patients on PPIs, atrophic gastritis, heart failure, renal failure, and a variety of tumors can give rise to it. So one has to be careful that when you're looking at serum chromogranin, it's in the right context. What we do know about it is that higher preoperative levels generally indicate a poorer long-term prognosis. So levels above 95 to 100 generally indicate a poorer prognosis. That if you get a 50% reduction immediately after treatment, then it generally, there are papers to suggest that it does indicate that this is a very good sign. But you have to be cautious. You cannot use this for follow-up except in patients who have been resected, in which the entire tumor has been removed. As we'll see, because these tumors are metastatic, you may sometimes not remove the entire tumor. So you cannot use chromogranin as follow-up in such patients. It has to be used very cautiously. Now, probably this is one of the most important slides. It's important for you that when you get a biopsy to be able to determine whether you're dealing with, you have to grade these tumors into G1, G2, G3, and neuroendocrine carcinoma. And this is based on, the most recent is the WHO 2019 grading. And essentially what this looks at is the mitotic rate and the Ki-67 index. And on the basis of these, one divides these tumors into these groups. Now, this is obviously only detectable on biopsy, whether that is an EUS biopsy preoperatively or whether it is a post-resection. And there is a certain amount of heterogeneity in the biopsy in this sense. You can get sampling error. So you may get a biopsy which suggests a very low-grade tumor, but you may if you had biopsied another, there's sampling error can occur in these biopsies, and you may actually sample a more aggressive area or a less aggressive area. But generally, this is what we use for determining the grade. As I mentioned earlier, because of the heterogeneity of these tumors, one also looks at their clinical behavior. There's no, most of the time, pretty much always, there's no need to go rushing in to operate. One can get an idea of how these tumors behave either on biopsy or from the SSTR PETs. As I mentioned, if they are, the uptake is better with the gallium PET, that suggests a low-grade tumor. And with an FDG PET, it suggests a high-grade tumor. Also, whether the tumor is extensively metastatic, that suggests that either it's been there for a very long time or that it's a higher grade tumor. So the general principle, and why I have outlined this in red, is that it's the G1, G2, well-differentiated, low and intermediate grade tumors which are respond best to surgery. And these are the patients that should be operated. Now, what about G3 tumors? This has, prior to 2017, there was only G1 and G2. And there was, so one isn't quite sure how exactly, whether these patients should be operated. And there's a difference of opinion in the literature. But the general consensus is that in selected patients, especially when the Ki-67 index is less than 50, then surgery is may be considered, for these patients. For the carcinomas which are poorly differentiated, generally surgery is not considered except in very, very exceptional circumstances. And so this constitutes a very small group of patients, and they have a very poor prognosis with surgery. So whenever we're talking about surgery, we're generally talking about G1 and G2, very low grade tumors which have a very benign, almost benign clinical course, towards the benign spectrum. The tumors also need to be staged based on their size and involvement of adjacent organs and vascular structures, and also whether the metastases are confined to the liver or to other extrahepatic sites or both. This also comes into account when one is planning surgery. So let's look at the non-functional tumors. These usually are diagnosed at a very advanced stage. Once they're over 2 centimeters in size, there is no controversy that these tumors should be resected, if at all. That is, I'm talking about the primaries now, should be resected irrespective. That is because once they cross the size of 2 centimeters, their prognosis on the long term has been clearly by multiple studies been demonstrated to be better with surgery. So there's no controversy here. Similarly, there's very little controversy with related to tumors which are less than 1 centimeter in diameter. I'm talking about non-functioning tumors here. These can be safely followed up with imaging, usually ideally at 6 months, but obviously if the tumor is remaining very static, you may lengthen it to 12 months. Imaging and surgery is not warranted in these patients except in very exceptional circumstances. Now, it is the tumors which are between 1 and 2 centimeters where there's a lot of conflict in the literature. And basically, patients you need to individualize treatment. There are some studies which have said that actually, instead of the 2 centimeter cutoff, we should be taking a 1.5 or 1.7 centimeter cutoff. But essentially, the principle is the same. You're going to decide if a patient is aged or has a very high comorbidity or poor performance status and needs a major surgery. You may choose not to do it at this point. You can wait and see how the tumor is progressing. If it's progressing rapidly, you may choose to, if there is clear tumor progression, and especially if the tumor is adjacent to a structure like the pancreatic duct, it's getting closer to the pancreatic duct, you might want to do a surgery earlier. If the patient has any symptoms, you would obviously, or there's a high risk of developing symptoms, you would offer them surgery based on the extent of resection, access to follow-up, and of course, as we've already mentioned, the grade and stage of the disease. So, and the patient's own opinion is also to be involved in the appropriate patient, obviously, in the decision making. So you need to individualize in this group. If we'll flip it the other way, who are the ones which we're not going to operate on? You're not going to operate on the less than 1 centimeter. You're going to do it selectively for 1 to 2 centimeters. G3, well differentiated, as I mentioned, you might consider doing it in patients with a Ki67 less than 50%, but you would think about it and not rush into surgery. And obviously, neuroendocrine carcinoma, you're not going to offer them surgery. When there's extensive extrahepatic metastasis, you need to, again, none of these is a contraindication for surgery. Each patient has to be decided on their own individual benefits. So and we'll discuss some of this in more detail. Extrahepatic metastasis, massive hepatic invasion, and patients who are at a high risk of postoperative complications, you would think twice before offering them surgery. For functional neuroendocrine tumors, as I mentioned, typically well differentiated, and you would, basically check to see whether they have MEN syndrome or not, and otherwise you would localize and stage them, and then resect whenever possible, especially when localized to the pancreas. If they've got extensive liver mets, then you obviously need to involve treatment of the liver mets as well in order to get rid of the hormonal syndrome, whether that is by surgery or by non-surgical methods. You'd have to decide. And especially if you're planning to use some kind of embolization procedure for the liver, for the functional liver mets, then it's recommended that you do that first before you do pancreatic surgery, if the pancreatic surgery involves a biliary enteric anastomosis, because doing embolization after a biliary enteric anastomosis has been associated with formation of liver abscesses within the tumors. I'm not going to go into detail about MEN1, except to say that you have to identify, particularly look for hyperparathyroidism, and which is the most common, and also pituitary adenomas. And it's the hyperparathyroidism which will usually require, if they have it, will require treatment first. And the most commonly associated tumors are gastrinomas and somatostatinomas. What is the nature of the surgery? When the tumor is very small and localized, especially if it's less than 2 centimeters in diameter, you want to spare parenchyma. The characteristic feature of these grade 1, grade 2 tumors is that they grow in size by pushing tissue away. They don't infiltrate. And therefore, it is quite, all one needs is a clear histological margin, and enucleation is perfectly safe and effective. Usually this is performed for the functioning, particularly insulinomas when they're picked up small, because with non-functioning tumors, it's unusual to have a very small tumor within the pancreas. Usually because they're non-functional, by the time they produce symptoms, they've usually become quite large. You could also do a central pancreatectomy or a mesopancreatectomy for a 2 or 3 centimeter tumor, which is in order to get a margin. But for the majority of these, particularly non-functioning tumors which present when they're large, you would require to do either a proximal or a distal pancreatectomy, very, very rarely a total pancreatectomy. And you need to plan this on the basis of the merits of the tumor location and size. Now, liver metastasis, there is a Frilling classification which is demonstrated here. This is Frilling 1, where you have small limited, it could be unilobar or bilobar mets, which are very easily enucleated or resected. In Frilling 2, you have a dominant tumor in one or other lobe, and you're likely to have other satellite lesions or other tumors as well. But the volume of tumor is limited to largely limited to one lobe. And then finally, you have Frilling 3, in which you have extensive tumors all across the liver with very little intervening parenchyma. And so for Frilling 1 and for Frilling 2, surgical resection is beneficial in these patients. There is one of the papers which had this statement, which is adagio con moto. I'm not sure if I'm pronouncing it right, but it means progress slowly. Don't be in a big rush to go operating on everything that you see in the liver. You can assess the behavior of the disease. You may want to give some of these patients lutetium therapy, and then wait for a little while if you have any doubt about the behavior of the tumor. But if you think you can resect it completely, then it's well worth doing. However, patients must understand that even when you have removed the tumor completely, there is a very high risk that these patients are going to get recurrent tumor. Almost 80 to 90% of them will ultimately get recurrent tumor in their liver once again. However, survival is excellent in many of these patients. And what you're doing it for is to try and prolong their life and as much as possible, because patients die not so much from the primary, but this is one of the major causes of death is liver metastasis. In some, you don't need to resect all the tumor, especially when you're dealing with symptomatic patients who either have a functional tumor or have got very bulky tumor in the liver. You could consider them for a debulking kind of surgery, which by definition means you're leaving tumor behind. Classically, for over many years, it used to be recommended that you should be planning to remove at least 90% of the tumor. But more recently, people have said that if you remove 70% of the tumor, the patients have some benefit. Liver transplantation is beneficial for selected patients, particularly in the Frilling type 2. Frilling 3 is usually too extensive for even for liver transplantation. There are very clear-cut guidelines which is very, very slightly between UNOS, the Milan criteria, and the Nanette's criteria. But essentially, you're looking at an unresectable liver metastasis. Histology, as I mentioned, grade 1 or 2 tumors. The primary must be within the drainage area of the portal vein. And importantly, the hepatic tumor replacement must be below 50% to get a decent result. That's why thrilling 3 may not be appropriate for transplantation. If the patient is symptomatic, this can go up to 75%. The primary must be resected and stable for at least 6 months. There should be no progression of disease over a period of 6 months. And if you get extrahepatic metastasis, particularly lung or bone, they should be delisted immediately and permanently. The 5-year survival is 50 to 70%, but disease-free survival is only 30% in such patients. And finally, I'd just like to talk about extrahepatic metastatic, certain special situations. This we see not uncommonly. You have a patient who comes in with in fact, I had one just last week, a patient with a large head of pancreas mass, not causing jaundice, incidentally discovered. And he's got extensive bilateral liver metastases. Now, should one offer this patient surgery? The answer is at the moment seems to be yes. The reason, this was a young guy, he was about 45. So the rationale for offering them surgery is that there are a number of studies which have demonstrated that survival, long-term survival, is improved by clearing the primary. And secondly, you prevent certain complications, for example, in this patient, portal vein obstruction or biliary obstruction or pancreatic ductal obstruction. And you also then have a better response to non-operative treatment for the tumors within the liver. However, these are all studies which are retrospective and small groups, and there is some controversy, and you may choose simply to do a biliary enteric bypass or something like that in very high-risk surgeries. Remember what I said, that without treatment, even these patients live for a very long time, and you don't want to, if you're going to do a Whipple on them, you better make sure that these patients are going to come through that operation safely. There are certain situations, and these are very select circumstances. Bone metastasis, among all the metastasis, I have no experience, but I believe that their outcome is worse, and one should probably not offer them surgery. And you can offer cytoreduction for peritoneal mets. If the tumor is unresectable in the liver, again, we are
getting out of time.
Finished. This is the last slide. So I'd just like to say that surgery is the mainstay of treatment for localized low to intermediate grade PNETs, especially if they're functional. Both, but functional irrespective of the size. And in all other situations, most other situations, treatment needs to be individualized. The role of a multidisciplinary meet is really important because there are so many treatment options. Thank you.
Thank you very much, Dr. Govil. That was an excellent overview. I think it has laid the foundation for our discussion. I think you covered the subject well and also highlighted the points of debate and discussion. I would now like to invite Dr. Mahbub Basade. He is a leading medical oncologist in Mumbai. He's attached to various hospitals. He's been leading the program at Jaslok Hospital, has pioneered bone marrow transplantation there. He's also the president-elect of the Indian Society of Medical and Pediatric Oncology. And he's got an extensive experience with this particular subject and would tell us today as to what systemic treatments should be offered when indicated. Thank you, sir. Thank you, Dr. Basade.
Thank you, Somil and Vikas. And sorry to budge in because, my talk was at 9:15. According to that, I have adjusted the other things. But the time allocated for me is just 20 minutes, and I will give the justice to it, and I will finish within 20 minutes. So the topic is medical management of pancreatic neuroendocrine tumors. Can you see my slides? It's not moving.
We can see.
Please
yes,
move
sir.
this window. What is happening? There is something come in between. Please remove this window. Okay. So let me just go ahead and give that the incidence of the neuroendocrine tumor is rising. As you can see from the SEER data, over a period of time, it is increasing. The pancreatic neuroendocrine tumors are much lower than compared to the lung or small intestine or rectum. And as Dr. Sanjay had just now said, that there are hereditary syndromes, and most important thing what to remember regarding the patients who develop pancreatic neuroendocrine tumors with an hereditary syndrome, that they have a more indolent course, and that's where you have to consider them separately for the management as well as the prognosis. As he also said, few pancreatic neuroendocrine tumors which are functional, and he showed a very nice diagram which I was not aware, which was really good, that insulinulomas, and you can have Zollinger-Ellison syndrome or VI tumors or glucanomas. So these are the various functional tumors, and if you have functional tumors, your management is going to be different than the patients who have non-functional tumors. So one has to be very much aware about their whether the patient has got functional tumor or non-functional tumor. The classification as again, we all know that pancreatic neuroendocrine grade 3 tumors are little aggressive. So grade 3 tumors could be poorly differentiated, or grade 3 tumors could be well differentiated. It's very important to differentiate between them, because grade 3 poorly differentiated are neuroendocrine carcinomas, or what we call similarly what we get in small cell lung cancer or pancreatic or the prostatic neuroendocrine carcinomas. So these are all poorly differentiated grade 3 tumors, and they have to be differentiated from the well differentiated by various molecular markers, as you can see from this slide, and as well as from the immunohistochemistry marker. So those patients who have neuroendocrine carcinomas are very aggressive, and they have to receive, everybody has to receive the chemotherapy. There is only one best option for chemotherapy choice is the cisplatin, either carboplatin or cisplatin, and the etoposide. So these are the two drugs that we use for all the type of small cell carcinomas. They are very responsive to chemotherapy, but unfortunately they recur very fast. So we hardly get any long-term survivals. At least in pancreatic neuroendocrine carcinoma, you have some sort of single digit or double digit 5-year survival rate, as compared in lung cancer or in the prostate cancer. We never get any 5-year survival rate of when the grade 3 neuroendocrine carcinoma is present for such patients. Various classifications are there, like we know that there is a TNM classification, there is an INETS classification, but people are saying that INETS classification probably has a better functional as well as the prognostic important for the patients of the pancreatic neuroendocrine tumors. Gallium dotatate or various other DOTA scans are an important diagnostic method for all such patients. Once we stage them and diagnose them, then we will treat them accordingly. For the patients who have a localized disease, surgical management is the most important thing, and this has been very well eluded by our colleague, and I'm not going to go into the detail. The patients who have less than 2 centimeter, and if they are resectable, can go ahead with the surgery, and those patients who are unresectable, probably they will fall into our domain. We don't know what is the adjuvant therapy for the patients who have been operated by you surgical colleagues, but there are various what we say that the stratification are available, so that we can identify the patients who will recur. So those patients who have T3, T4 tumors or have high Ki-67 index, these are the patients who probably may need some treatment in the adjuvant setting, but we don't still have any data. So risk classification is also important. Even if you operate, there are late relapses are known, and that can happen even after 5 to 10 years. There are various genomic prognostic factors which we are still not aware of for such patients, and they will all require further confirmation with the various other things. So liver mets are more common as far as the distance recurrence is concerned than the local recurrences. So these are the things which we are aware, that stratification of the risk of relapse is crucial for development of an adjuvant strategies. At present, we do not give, unless there is a gross residual disease, some adjuvant treatment for majority of the patients. So the patients who have an advanced disease, we have multiple treatment options available for such patients, right from surgery to liver directed therapy to somatostatin analogues and various targeted therapies, chemotherapy and Prrt therapy. So again, if the patient has a primary resectable, go ahead and do the resection. If the patient has resectable liver mets, again grade 1, grade 2 can go ahead and do the surgery. If there are few remaining, then one can go ahead with the RFA or TES or TER. And the patients who do not get operated, these are they can undergo liver directed therapies in the form of the TES and TER, which are also very important aspect of the treatment management. But the patients who cannot undergo surgery, or even they cannot have liver directed therapy, but they have multiple metastases, for such patients, what we have is what we call as chemotherapy or systemic therapy. For such patients, they have multiple therapies, have chemotherapy typically for the pancreatic, but there are certain targeted therapies which I am going to allude for role the differently. So how to select the best possible therapy? That is based on the tumor burden, Ki-67, and the rate of progression. So if you have somebody who is inoperable, high Ki-67, high tumor burden, should go ahead with the chemotherapy, and there are various other options in the form of targeted therapies. So octreotrides and lanreotrides, these are the two somatostatin analogues which have been used in neuroendocrine tumors. And remember, very important thing, that in pancreatic tumors, lanreotride is the only one which has been studied. Octreotride has been studied mostly in the non-pancreatic neuroendocrine tumors, but still I see a lot of my colleagues have been using octreotride for non-functional pancreatic neuroendocrine tumors, which should not be used otherwise. So for the patients who have a pancreatic neuroendocrine tumor, streptozotocin with 5-FU this is one of the chemotherapy option. The other chemotherapy option is temozolomide with capecitabine. The other targeted drugs like everolimus, sunitinib, or bevacizumab are also being used for the patients who are inoperable. Prrt therapy, and obviously the next talk is going to be on the Prrt therapy, so I'm not going to go into the detail about that. But the somatostatin analogues, as I mentioned, that prometride was the first one which octreotride was used for grade 1 patients, and they have excluded pancreatic neuroendocrine tumors. Then another one is clarinet trial, where they had patients who are the pancreatic neuroendocrine tumor, and unfortunately this lanreotride is not available for our Indian patients, and there are some patients who get it. So if you see, the progression-free survival with lanreotride is much more as compared to octreotride. So it is a preferred drug, and patients who have received pancreatic who have received the lanreotride, median progression-free survival has not reached, and they also have a long-term survival, overall survival somewhere around 35 to 40 months. Irrespective of the liver tumor burden, lanreotride works. So it is a better that you should use the lanreotride for the patient. The other targeted therapies are mTOR inhibitor like everolimus, or anti-angiogenic drugs like sunitinib or bevacizumab. So these are the two other drugs which are being used in combination. The sunitinib is used in the dose of 37.5 milligram, while everolimus is used in 10 milligram every day. If you see the responses of both these two drugs, the progression-free survival is somewhere around 11 months. But the toxicity is huge. We use drugs, both the drugs in the renal cancer as well as in various other malignancies. Both the drugs are very toxic to the patient, depending on the toxicity profile of the patient and what the patient will tolerate. Like for example, everolimus has got a lot of mucositis, hyperglycemia. So those patients who are diabetic, we don't use everolimus in such patients. While hypertensive patient, sunitinib is a problem. So we have to be very careful in choosing either of them based on the comorbidities of the patients, and if we want to use for such patients. Chemotherapy has been known to improve both progression-free survival as well as an overall survival. In non-pancreatic neuroendocrine tumors, response rates are poor, somewhere around 10%, while in pancreatic neuroendocrine tumors, the chemotherapy has good response rate ranging from 20 to 50%. And as you can see from the first plot that the response rates are quite good in the patients who have pancreatic neuroendocrine tumors. So various chemotherapy protocols, I'm not going to go into the much detail. So my streptozocin along with the 5-FU, or you can use along with cisplatin or adriamycin. The other chemotherapy option is temozolomide and capecitabine. This is a monthly cycle, and if it has been used in various trials, median PFS somewhere around 18 months, which has been little better than what was with the earlier targeted agents. As you can see over here, the patients have been randomized to the temozolomide versus temozolomide plus capecitabine arm, and what we can see here that the median progression-free survival practically doubled when you add capecitabine to 22 months, and median OS has not reached. So this is one of the good treatment options for metastatic pancreatic neuroendocrine tumors where surgery is not possible and toxicity is not much. One can get assured that the toxicity is quite good, and as far as patients' life is concerned. We are going to hear Prrt therapy in the next topic, but that is another excellent option for the patients who have both pancreatic as well as non-pancreatic neuroendocrine tumors. And we all know that the response rates are also somewhere around 50 to 60% for the patients who receive Prrt therapy, and overall survival ranging between 40 to 70. So it is a great option, but when to use, we still don't know. What sequence we should use, we still don't know. So what are the newer options which are available, which are going forward, which we are going to see? The fewer drugs, like we use lenvatinib again for renal cell carcinoma. It's an anti-angiogenic drug. Cabozantinib is another anti-angiogenic drug. These are the drugs have been also tried, are getting tried in various trials in pancreatic neuroendocrine tumors, but we still don't know. So this is a complete trial this has been completed in December 20. So probably December 2022, we will have the trial of the data available for this. It will be straight away randomization of the all GI pancreatic neuroendocrine tumors, lutetium versus everolimus. But unfortunately, the other arm should have been the chemotherapy rather than the everolimus. So I just showed that everolimus median PFS is 11 months, while chemotherapy is 22 months. So you already have a bias here in favor of the lutetium, and which probably you are going to see in that. So that will be a little unfortunate for us, that we will not have a good idea. So this is again trial of chemotherapy. This should have been the other arm in that trial, the streptozocin with 5-FU and compared to the everolimus. So this is also we are going to see what is going to happen if you are going to use either targeted drug or chemotherapy. So sequence is still not known, what should be used first and what should come later on. The newer anti-PD-L1 drugs, like for example pembrolizumab, as people have been trying, very small numbers, very small responses. Same thing happened in the lung cancer, but now we know that what subgroup of the patient should receive this kind of an immunotherapy. So going forward, probably we may see some new data, better data with the pembrolizumab or various other anti-PD-L1 monoclonal antibodies. So take home message from my side that pancreatic neuroendocrine tumors are rarer than the other neuroendocrine tumors compared to the lung or the GI, and the incidence is rising over a period of time. The grading and Ki67 is very important, whether G1, G2, G3, and in G3 we have 2 neuroendocrine carcinoma as well as well-differentiated neuroendocrine tumor, and G3s are aggressive one, but they do not behave like neuroendocrine carcinoma. So they should not be treated with the chemotherapy like cisplatin and etoposide, but rather a chemotherapy like temozolomide and capecitabine should be used. The patients who are an operable or localized disease should go ahead with the surgery. Even if they have metastatic disease and resectable, Surgery has a definite role which improves overall survival. Recurrences are known even after 10 to 15 years. Liver-directed therapy has also got an important role in prolonging survival in such patients, and various other medical managements or systemic therapy like somatostatin analogues like lanreotide, other targeted therapies, anti-angiogenic drugs have important role in such patients. So what we should learn going forward is that what sequence to be used and what should come first if the surgery is not possible, if the liver directed therapy is not possible. So that is an important what we will be getting the data from the next in 1 to 2 years. So selection of systemic treatment relies basically on the tumor characteristics as well as the disease burden and the what we know about the patient characteristics. So if whatever the comorbidities of the patient has, depending on that, we have to choose the treatment. And thank you very much. So I finished in time, and I will be available on phone. So if there are any questions during the case-based discussion, definitely. And thank you for me allowing me to present on the this day. Thank you, Vikas.
Thank you. Thank you so much, sir, for enlightening us about the vast experience in this field. For the next topic, I would like to invite Dr. Swagar Das. Dr. Swagar Das is a nuclear medicine physician and have over 15 years of experience in this field. He is associated with the Sarvodaya Hospital and Research Cancer Center in the Faridabad, and his specialty in the Prrt for oncology and non-oncology, and for the molecular theranostics. Now I would like to invite Dr. Swagar Das.
I hope my slides are visible.
Yes, yes, it is.
Thank you. First of all, I would like to thank Dr. Vikas and Dr. Somil to invite me to this forum to talk on nuclear theranostics in pancreatic neuroendocrine tumor. Initially, the topic was given to me was diagnosis and treatment. I mean, theranostics is the recent concept, so I changed the topic to incorporate that theranostics words. Now, to start with, the pancreatic neuroendocrine tumors, they originate from the neuroendocrine cells in the pancreas. These are 1 to 2% of all the pancreatic neoplasms. Clinical incidence has been rising. Increasing number of patients are getting diagnosed in earlier stages, possibly due to improved diagnostic methods, in particular endoscopic and imaging techniques. Two groups, according to the presentation of the hormone-related symptoms, like non-functioning pancreatic neuroendocrine neoplasm or functioning neuroplasm. 30% of peanuts are functioning. They release peptides and hormones, vasoactive intestinal peptide, gastrin, insulin, glucagon, etc. They may be associated with some genetic disorder like tuberous sclerosis, von Hippel-Lindau disease, and Main-1 syndrome. It has already been discussed by my previous speakers. These are of the three main grades: grade 1, grade 2, grade 3. Grade 1 is well differentiated with Ki67 less than 3%. Grade 2 is well differentiated with Ki67 is 3 to 20%. And grade 3 is either pancreatic neuroendocrine carcinoma or poorly differentiated pancreatic neuroendocrine tumor with Ki67 more than 20%. Grade and stage, they determine the patient prognosis. Tumors less than 20 centimeter, very good prognosis, indolent grade or biology. Localized tumors like stage 1 or 2 that qualify for resection are cured by undergoing solely surgery. It has been clearly outlined by Dr. Sanjay Govil, sir. Grade 3 peanuts, more favorable prognosis than poorly differentiated pancreatic neuroendocrine carcinomas with a 5-year survival rate of approximately 29%. As it already been discussed, surgery is the main and most significant treatment, as well as the only method to cure the disease. The patient who are unsuitable for surgery, the systemic therapies like peptide receptor, radionuclide therapy, chemotherapy, targeted therapy, and somatostatin analogues. Somatostatin receptors, all these systemic therapies, they depend on the presence and abundance of somatostatin receptors in the tumors. These receptors are a superfamily of G protein coupled receptors and can be activated by their ligands to exert their physiological functions. These are of 5 subtypes. SSTR2 is the most commonly expressed subtype in PNET. Positive expression of SSTR2 and SSTR5 has significant correlation with improved overall survival. This is the slide showing all the somatostatin analog like chemotherapeutic drugs and radiopharmaceutical with their affinity towards all the 5 type of receptors. You can see these gallium labeled pharmaceuticals and yttrium labeled pharmaceuticals and lutetium dotatate, they have affinity for all the 5 receptors. In brief, HSCC staging for pancreatic neuroendocrine tumor. T stage depends on the size. Apart from that, invading of duodenum or CBD, adjacent organs or vessels, regional lymph nodes, and distant metastasis. As we already know, bone is the most common site of distant metastasis. Now coming to a role of nuclear medicine imaging in neuroendocrine tumor, that is somatostatin receptor based imaging, should be used for staging of the well-differentiated NET, including all jejunal, ileal, colon, duodenal, pancreatic, thymic, and bronchopulmonary, gastric type 2 and 3, rectal, all except for small lesions which are less than 1 centimeter in size, appendix, all except less than 2 centimeter tumors, in all locoregionally advanced or metastatic tumors, and in all biopsy proven NET with unknown primary location. These are the broad indication to get a somatostatin receptor imaging in a patient. Classically with SPECT, we used to use indium 111 or technetium 99M somatostatin receptor scintigraphy. Both have been used for NET staging since long, but they have invariably lower sensitivity than PET-based imaging. This is SPECT somatostatin receptor imaging, normal biodistribution, the kidney and bladder. This is the renal excretory route. Liver has diffuse, low uptake, spleen, marked uptake, pituitary gland modest, thyroid gland modest, and occasionally large bowel. The sole purpose of this slide is to outline that if there is a lesion in liver or spleen, then with somatostatin SPECT imaging, these are going to be missed. These are the few images showing some pancreatic NET. This is a case, biopsy-proven pancreatic neck NET with multiple hepatic metastasis. The imaging is technetium 99 labeled Heineck top. This is another indium 111 DTP octreotide whole body and SPECT CT scan. As you can see, there is the primary malignant mass along the pancreatic tail with multiple hepatic metastasis. Apart from that, there is one left supraclavicular lymph node. Now coming to PET-based imaging, that is DOTA-NOC or TOC or TET PET-CT. These are cell surface somatostatin receptor imaging, diagnostic role in gastroenteropancreatic neuroendocrine tumor, bronchial NET, paragangliomas, meningiomas, and oncogenic osteomalacia. Better for low-grade NETs than FDG PET and vice versa. Together with FDG PET-CT, it allows identification of tumor heterogeneity, which provides prognostic information and can be pivotal in guiding biopsy. It also allows optimal patient management, including theranostic application of Prrt with alpha radionuclide like actinium-225 or beta radionuclide like lutetium-177, and then in restaging. These are the common gallium labeled radiopharmaceutical available for imaging. As you can see, these are gallium DOTA-NOC, gallium DOTA-TET, and gallium DOTA-TOC. All the half-life, production, injection activity, route of synthesis, everything is similar, normal biodistribution, everything is similar, apart from only the receptor sensitivity. TOC is for SSTR2 and SSTR5. TATE is predominant affinity for SSTR2, and NOC is for SSTR2 predominantly. Apart from that, SSTR3 and 5 as well. Clinical application is also same for all the three. A systematic review and meta-analysis of gallium-68 DOTA-TATE compared with indium 111 DOTA-TATE octreotide found that there are 3 studies which compared the 2 radiopharmaceutical head-on in the same patient. And gallium DOTA-TATE had an estimated sensitivity of 90.9%, specificity of 90.6%, and were more sensitive than octreotide scan with SPECT radio tracers. Another advantage of the PET tracers is that quantification of the tumor uptake of tumor can be performed, which is not possible with SPECT. And also, SUV max of the tumor of the uptake of gallium-68 DOTA-TOC has been found to correlate with response to PRRT. This is a normal case of gallium DOTA-TOC in a patient. The scan is normal. Only thing is to be outlined is gallium DOTA-TOC, there is a physiological uptake in adrenal and uncinate process, and many times they are being misjudged as lesions, but actually they are the physiological uptake in adrenals and uncinate process of pancreas. This is the same case where the gallium DOTA-TATE had been done and indium 111 octreotide scan has been done. As you can see, the gallium images, they are clearly showing multiple bony lesions, supraclavicular lymph nodes, liver lesion, everything. However, the indium octreotide scan is showing only the supraclavicular lymph node. So, I mean, this scan clearly shows gallium DOTA-TATE or PET-based somatostatin receptor imaging, they clearly exceeds in sensitivity and specificity than SPECT radiotracer imaging of somatostatin receptors. This is a gallium DOTA-TATE PET-CT of well-differentiated NET of pancreatic body, as you can see, clearly lighten up. Another case of insulinoma along head of the pancreas. This is the insulinoma along the head of the pancreas. We have another one very good gallium-based radiopharmaceutical for insulinoma, that is Extendin PET-CT. Extendin is glucagon-like peptide 1 receptor imaging with Extendin 4. More sensitive, I mean more than 94%, and more specific modality to detect insulinoma. Effective treatment of insulinoma is surgical, and that is the reason pre-op localization of the tumor is critical for successful post-op outcome. Useful diagnostic adjunct in patient with main 1 syndrome and endogenous hyperinsulinemic hypoglycemia. Few borrowed slides. These are the slides from Journal of Nuclear Medicine. As you can clearly see, there is a very homogeneously enhancing lesion along the pancreatic tail, which is being lightened up with Extendin. This is one insulinoma along the pancreatic tail. This is another insulinoma along pancreatic tail with a metastatic lymph node. So if we now go to NCCN manual, where does this somatostatin receptor-based imaging they are placed? In non-functioning pancreatic tumors, somatostatin receptor-based imaging with gallium DOTA-TATE PET-CT preferred over somatostatin receptor scintigraphy, I mean SPECT scintigraphy, and they are being advised as appropriate in all the non-functioning pancreatic tumors. So also in gastrinoma also, they are being advised in NCCN staging, in insulinoma, glucagonoma, and VIPoma. Now coming to FDG PET-CT. FDG PET-CT is the workhorse of oncological imaging. Now the question arises whether FDG has any role in neuroendocrine tumor of pancreas, whether it be low grade or intermediate grade or high grade. Let's talk about it. Typically, as Ki67 and grade of the tumor increases, the intensity and extent of FDG uptake in the tumor also increases. FDG positivity is a very strong negative prognostic factor in such tumors. Preferred pressure for G3 entities as well as for some high-grade G2 tumors. A Ki67 more than 10% is often considered as a cutoff to get a FDG PET-CT done. It should also be considered if the lesions are identified on anatomical imaging, which are not SSTR tracer avid, or if they are progressing fast, as this could represent dedifferentiated disease. So currently the combination of FDG and gallium-68 labeled somatostatin receptor imaging is often performed together in patients with G2 or G3 tumors, or if there has been relatively quick progression of disease to determine if there is discordant disease. So, I mean, the selection of a patient for PRRT also depends on depends on the scan results of both gallium-68 somatostatin scintigraphy plus FDG. If a patient is gallium-68 SRS positive and FDG negative, that means all the lesions have abundant somatostatin receptor and that patient is suitable for PRRT. If the patient is gallium-68 SRS positive and FDG positive, but with discordant lesions, this is not suitable for only PRRT. Probably chemotherapy or peptide receptor chemoradionuclide therapy is suitable in this case. And gallium-68 SRS negative, FDG positive lesions, definitely chemotherapy or local treatments. PRRT doesn't have a role in such cases. Now, this is a case in which upper palate FDG has been done, and the same case with the gallium-68 dotatate scan. If you can see the lesions in supraclavicular lymph node, pancreatic primary, these are all FDG avid, apart from there is a bony lesion, but the same corresponding images of gallium dotatate. As you can see, the supraclavicular lymph node is gallium negative, bone lesion gallium negative, and the pancreatic primary is showing very low gallium avidity in comparison to FDG avidity. Now coming to therapeutic application of nuclear medicine in pancreatic entity, that is PRRT. PRRT is a treatment option for patients with metastatic, inoperable, well-differentiated entities that show good uptake of the radio-labeled peptide on diagnostic imaging. We have two most frequently used therapeutic radionuclides, that is yttrium-90 and lutetium-177. These are therapeutic because they emit gamma rays and they emit beta rays, and beta rays is therapeutic. As you can see, these are the physical characteristics compared between the two. Half-life, lutetium is 6.75 days and yttrium is 2.67 days. So indication and patient selection for PRRT. In patients with positive somatostatin receptors scintigraphy, somatostatin analogues should be considered as the first-line treatment. In patients with mid-gut entity who require systemic therapy, having progressed through somatostatin analogues, PRRT is usually the preferred next treatment option. PRRT also considered in patients with entities of other primary sites, particularly when there is extensive disease, extrahepatic disease, and good uptake on gallium-68 based SRS imaging. In pancreatic entity, there are more therapeutic options, including cytotoxic chemotherapy, everolimus or sunitinib, and PRRT, as just discussed in the previous lecture. So the management of locoregionally advanced disease, what NCCN guideline says, I mean, in evaluation, the somatostatin receptor based imaging, gallium PET imaging is definitely preferred. And if the patient is progressing on octreotide or lanreotide, then PRRT with lutetium dotatate if somatostatin receptor positive imaging. Hepatic lesion radioembolization can also be an option. So now what are the inclusion criteria of PRRT? I mean, the patient who can be fit into the PRRT therapy, inoperable or metastatic well-differentiated G1, G2 entity, well-differentiated G3 entity can be considered if it shows sufficient uptake on SSTR imaging, sufficient tumor uptake on a diagnostic SRS, plus FDG PET-CT demonstrating no discordant sites of uptake, sufficient bone marrow reserve, creatinine clearance more than 50 ml per minute, KPS more than 50 or ECOG 1 or 2. Expected survival should be more than 30%. So exclusion criteria for PRT are significant sites of active disease identified as contrast enhancing lesion or CT MRI that lack SSTR expression, that is negative SRS, moderate to severe renal impairment, impaired hematological function, hepatic impairment, cardiac impairment, moderate to severe right heart valvular disease, or pregnancy or ongoing lactation. Clinical efficacy according to NETTER-1 trial, objective response rate, that is either CR or PR, is almost 29%. Average disease control rate, that is stable disease, almost 81%. Median PFS with PRT is almost 36 months, and it also improves quality of life. Now, one newer concept is combination PRT, that is combining both the radionuclide available for PRT, that is yttrium-90 and lutetium-177. Why? Because yttrium-90 has the advantages for larger tumors due to its longer beta particle path length, whereas lutetium-177 would be better suited to smaller lesions. So if there is a patient with bulky disease with variable size of tumors, then using yttrium-90 dotatate octreottate followed by lutetium-177 dotaoctreottate for the patient, it demonstrates relatively high response rates and survival. These are sporadic trials, not in the mainstream, but definitely promising. Sorry. Another one I just talked about a few slides back, that is PRCRT, that is chemotherapeutic agents with radiosensitizing effects such as 5-fluorouracil and its prodrug capecitabine have been combined with PRT. They are referred to as peptide receptor chemoradionuclide therapy. So PRCRT rather than PRT alone could be more appropriate for those with higher grade entities. With shorter survival associated with these tumors means potential benefits of chemotherapy are more likely to outweigh the risk. Gallium-68 SRS positive and FDG avid entities with discordant lesions treated with 5-FU and lutetium dotatate, they reported radiological response rates of overall response in 30%, stable disease in 68%, and progressive disease only in 2%, with progression-free survival almost 48 months. Now, the newest concept in PRT is alpha PRT. Till now, what I talked is lutetium and yttrium, they both emit beta rays. The newer radiotracers like actinium-225 and bismuth-213, they emit alpha rays. Alpha rays have small particle range of 50 to 80 micrometer. So they have relatively higher biological effectiveness and potential to induce cell death when as compared to lutetium or yttrium based PRT. Being evaluated in lutetium dotatate refractory patients with encouraging results. So this is a schematic diagram showing diagnostic and therapeutic options in one slide. Diagnostic imaging with gallium-68 dotatate. If they are positive for target, you can target all the positive lesions with PRT, either lutetium dotatate or alpha dotatate. So gallium octreottate PET-CT scan, you can see the liver lesions showing peripheral gallium uptake. Same patients were infused with lutetium PRT, followed by the SPECT-CT scan was done, and you can see the uptake of the lutetium therapeutic radionuclide along the margin. Central is necrotic, non-active tumor. Only the active tumor is taking up the therapeutic radionuclide. This is a case showcasing pre and post lutetium dotatate therapy, huge hepatic mass, and it has regressed. Then in subsequent scan, this is the subsequent scan of the same patient. Now coming to main 1 syndrome, a short slide only. In main 1, what is the role of nuclear medicine? That is parathyroid system maybe with SPECT-CT scan, or pancreatic neuroendocrine tumor, you can have gallium dotatate PET-CT. So thank you so much. This is all from my side. If you have any questions, I'll be happy to take it up. Thank you so much. Over to you, Dr. Vikas.
Thank you, Dr. Swagar. It was a very lucid and very detailed talk about all the things. I had one question for a primary patient who has come with a PNET. So we would go with the first therapy of choice, first investigation of choice would be gallium nitride scan or FDG PET scan?
Dr. Pinky, we will take the questions in the last after completing all the talks.
Fine.
Yeah.
I welcome Dr. Chetan Kantharia. I think sir doesn't need any introduction. He's a HPB faculty and he's a chief and head of Department of Surgical Gastroenterology at KM Hospital. He has more than 100 publications and he's a awardee of many international fellowships like Hargobind Traveling Fellowship. So over to you, sir, Dr. Kantharia, who's going to talk on a case presentation.
So thank you, Dr. Pinky, for such a wonderful introduction. And at the onset, I would like to thank Dr. Vikas and Dr. Saumil for having me on board on this wonderful forum. So after having listened to this wonderful overview from Dr. Sanjay, the oncological treatment from Dr. Basade, and the importance of radionuclear medicine in pancreatic neuroendocrine tumor, I take you all to real-time 2 cases of how one faces in our day-to-day clinical practice. So the first case is a 68-year-old female who presented with intermittent epigastric burning pain and watery diarrhea since last 1 year. She used to get temporary relief with symptomatic treatment given by family physician. There was no history of nausea, vomiting, melena, or tenesmus. And she had unremarkable medical and family history. Her physical examination revealed mild tenderness in the epigastrium. Her USG abdomen was normal, and blood, biochemical, and thyroid function tests were also normal. So based on her symptomatology, we first did an upper GI endoscopy, which was normal. And because of her symptoms of watery diarrhea, we thought of doing a serum gastrin level, which we found to be markedly elevated. Her serum calcium and parathormone levels were also normal. So because her serum gastrin level was elevated, we next did a CT scan, which showed a solid hypervascular lesion around 2 into 1.7 centimeters in the body of the pancreas as seen here. We followed it up with a somatostatin receptor scintigraphy, which showed a focus of intense radiopharmaceutical uptake compatible with neuroendocrine tumor in the retroperitoneal pre-aortic region. So with this findings, we made a diagnosis of gastrinoma and did enucleation of the lesion. So brief, this is the histopathology where the H&E staining shows a typical trabecular pattern. The immunohistochemistry, which is positive for chromogranin and cyanoptophyte. So basically, gastrinoma are characterized by gastrin overexpression resulting in ZD syndrome. Majority of them are sporadic, with 20% being associated with men type 1 syndrome. The incidence is 0.5 to 2 million per million, with the incidence in males being higher. It usually occurs between 20 to 50 years with typical symptoms of abdominal pain, chronic diarrhea, which is usually present in 2/3 of cases. Occasionally, patient may present with gastric G reflux and symptoms suggestive of peptic ulcer. So 80% of time they are localized in the gastrinoma triangle, and the gastrin level is usually 10 times than the upper limit, which is diagnostic of gastrinoma. Though you may get lower levels associated with MEN1. Intraoperatively, you may use intraoperative USG to localize the lesion. However, the final diagnosis is based upon the pathological and immunohistochemistry. Surgery is the only curative treatment, and usually follow-up is recommended in form of a CT or MRI every 3 to 6 months, and PET CT at the end of either 1.5 to 2 years thereafter. So at this point, I would like to ask my Dr. Vikas, is it okay if I ask questions, or we'll take it later on?
You can ask, sir, because this case presentation
yeah.
is like question answer
At
session.
this,
Yes.
At this point, I would like to ask the esteemed panelists, what do you think about the this case? Would you also have proceeded to do serum castrin level based on the symptoms, or you would have done it otherwise? Dr. Sanjay?
Sorry, I'd muted. Yeah. So I mean, it's very difficult to say. It's a fairly non-specific symptom, but I think you know, when you put it in a forum where we're discussing neuroendocrine, the moment you put it up, the first thing that came to mind is either gastrinoma or VIPoma as another possibility. But in a clinic, it's a lot more difficult to pick up on these symptoms. So kudos to you guys for having picked it up. I presume this was not the first thing that you thought of, but you know, it's good that you did think of it. And I just wanted to bring out a point here that I was a bit surprised to see that the upper GI scopy was completely normal, and that would make me think of the possibility of this patient being on PPIs, which would falsely elevate the serum gastrin level. So again, I'm presuming that you know, you would have stopped the PPIs for at least a week and you know, all that sort of stuff before checking. So that's what I'd like to say here.
So I think what Dr. Sanjay has raised a very important point, that when you do a serum castrin level, you have to take into consideration that whether the patient is on PPI or not, and if it's on PPI, then you have to take it. The level should be much higher than otherwise. Pinky, you have been dealing with a lot of gastrinomas. I know when you were with us. So what do you think? You would have gone ahead and done a serum gastrin, or you would have done the other workup?
Maybe I would have done a CT scan first, sir. I would not have thought about it. And
What?
since the patient has, I would have done a CT scan first.
Okay. Okay.
Then picked up the lesion and then did the workup. Maybe I would have done that way in the clinic. I would not have done a hormone test first.
Okay. Dr. Vikas, what about you? Because the symptomatology was very clear, watery diarrhea since last 1 year.
Actually, watery diarrhea doesn't come to surgeons too much. So first of all, as a surgeon, we will like to see the anatomical disease. So we will definitely go for the imaging first, then go for the biochemical testings in the retrograde manner. Yeah.
Okay. So now we come to the second case.
Chetan, just one question.
Yeah,
I could come in. Yeah, I had the question with respect to your surgical approach. You said you enucleated the lesion. Now, was that a decision you took intraoperatively, or was it a planned enucleation?
No,
I mean, how did you decide on
it? Was an intraoperative decision. It was a well encapsulated lesion. So basically, you should be doing parenchyma preserving. And it was well away. So that is why we went ahead and did an enucleation.
And presumably you would do a frozen section to confirm the completeness.
Yes.
And you did a laparoscopy first? Laparoscopy or directly open?
No, directly open.
Okay.
So
can I just make one more point, Dr. Chetan?
Please, Sanjay.
If you're doing an enucleation in these patients, it's also a good idea to do at least a regional lymphadenectomy because there's a high incidence of 60 to 90% of these are malignant, and the likelihood of lymph nodal metastasis is high. So lymph nodal for sampling at least should be done when you're enucleating.
Because I think with respect to the diagnosis, even if the serum gastrin is raised, the presence of a hypovascular lesion, of course, the symptoms are there. Still, it is not conclusive of a gastrinoma, isn't it? I mean, you could still have a false elevation of serum gastrin because of PPI. So actually, the pre-op diagnosis is that of a neuroendocrine tumor with simply elevated gastrin.
That is what I said, that the final diagnosis would depend upon the histopathology and the immunohistochemistry. Okay. So we now come to the second case. So this is a patient who is a 45-year-old gentleman who was referred to us from a peripheral hospital with frequent episodes of fatigue and irritability since last 6 months. He required frequent breaks during work with impairment of concentration and tremors and shaking like movements without losing his consciousness. And these episodes typically resolved after eating. He also had a history of a road traffic accident 2 months back following loss of consciousness due to hypoglycemia. As far as his other medical history was concerned, he was an hypertensive, well controlled on amlodipine, and he had a history of elective laparoscopic cholecystectomy done 5 years back. His family and social histories were non-contributing. So as far as clinical examinations were concerned, his vital parameters were normal. His CNS and CVS and abdominal system was normal. Hematological and biochemical investigation was within normal limits. We admitted him because he was referred from a peripheral hospital in rural Maharashtra. So we admitted him for observation and further investigation. And within few hours after admission, the patient developed an episode of irritability and exhibited tremor. So at this particular moment of time, we got his blood glucose level done, and we sent his serum insulin and C-peptide levels, which all came, serum glucose level came as 50 milligrams, insulin was 40, and C-peptide level was 4.8. And the symptoms also resolved following administration of IV glucose. So we made a clinical diagnosis of insulinoma and went ahead and did a CT scan, which showed a single enhancing lesion located at the head of pancreas, measuring around 1.2 centimeters, and there were no distinct metastasis identified. So based on this finding, we went ahead and did a resection of the tumor, where we again enucleated the tumor. So this is the histopathology, where it shows a nest of polygonal cells with abundant eosinophilic cytoplasm, which is consistent with neuroendocrine tumor, and the immunohistochemistry positive for synaptophytes. So as far as insulinoma is concerned, the annual incidence is 4 cases per million. It more commonly occurs in women than in men. They're typically present in 5th decade of life. The MEN type 1 syndrome median age is 2nd decade of life. Typically, they are sporadic, benign tumors, solitary, and usually small. 10% are multiple and occur as a part of MEN type 1 syndrome. And the diagnosis is often delayed due to non-specific symptoms, as in our case. Most of them present with hypoglycemic episodes resulting from inappropriate behavior. And symptoms can include diaphoresis, tremor, palpitations, tachycardia, neuroglycopenic symptoms such as personality changes, weakness, confusion, syncope, seizures. As far as diagnosis is concerned, Whipple's triad is diagnostic, which comprises of hypoglycemia, neuroglycopenic symptoms, and prompt relief of symptoms following administration of IV glucose. The gold standard for biochemical diagnosis is plasma glucose, serum insulin levels, C-peptide, and proinsulin during a 72 hours fasting. This helps in detecting in 99% of cases the diagnosis. And approximately 65% of patients experience hypoglycemic episodes within first 24 hours of fasting. Localization, usually you require more than one imaging modality. So you could do either a CCT or MRI or EUS, a combination of either. Very rarely intraarterial calcium stimulation tests with hepatic venous sampling or angiography. I think nobody does hepatic venous sampling now, and arterial stimulation venous sampling again very rarely done. Because of their small size, localization is often difficult, and therefore intraoperative ultrasonography becomes very important. And you require a high index of suspicion based on findings and symptomatology correlating with lab test and image. So treatment, surgical removal is the gold standard treatment and is curative. So again, I would like to ask, I think this case is fairly straightforward, and there is no diagnosis, no second thought with regards to diagnosis depending upon symptomatology. Pinky, your thoughts, because I know you have done a lot of insulinoma.
Sir. So I wanted to ask you, did you do a MRCP prior to the surgery to see the relationship with the pancreatic duct?
No, Pinky, we did not do, because we had this intraoperative ultrasonography, and the CT showed that it was very far off from the main pancreatic.
So this was laparoscopic, I presume.
No, this was also open. Sorry.
Open. Okay, why, sir? This was clearly this thing. No?
This was clearly, but this we did it open.
Okay, okay. Nice case, standard actually.
Perfect.
I would like to ask other panelists, would they recommend, not in this was a very exophatic type of lesion. Would you recommend doing a MRCP prior to any tumors for a relationship of pancreatic duct? Suppose we are attempting laparoscopic enucleation. Dr. Sanjay and Somil, would you do that?
Thank you. Yes, I think one would, and although I have not done it, there are articles about prophylactic stenting of the pancreatic duct before enucleating tumors which are very, very close to the pancreatic duct in order to reduce the risk of things. So I think if on the CT there's any kind of doubt that it might be close, then it's probably a good idea to.
Pinky, it's very important for all the others that before you embark on enucleation, it's very important that you establish the relationship of the lesion with the duct. It should not close proximity with the duct.
I think in this particular case of Dr. Chetan, even in the previous case, it was good that both lesions were enucleated completely, because this is clearly, one has to weigh the morbidity of a Whipple versus, especially I think the pancreas would be soft versus an enucleation. So certainly I think in this case, if these have been benign lesions, have been enucleated completely, sparing the morbidity of a Whipple, that is certainly the right thing to do.
Another thing which we have seen in our experience, I think whether Dr. Pinky remembers or not, when at times, occasionally, these lesions may be multicentric. So you may remove one lesion and keep behind the second, and the patient's symptoms still persist. And at times, in those times when I was a resident, we had to go in second time again to remove the remaining lesion.
Yeah. I think that time we did not have intra-op ultrasound.
Yes.
We used to have struggle. Yeah.
Dr. Vikas, what are your thoughts and comments?
Yeah, exactly. If the CT is showing the distance from the lesion, then we may not embark every patient for the MRCP or the ductal workup. But if there is a doubt, if the lesion is very close to the duct, then we have to rule out the involvement of the duct.
Right.
That's it. Yeah.
Any other panelist wants to make a comment?
I think.
Dr. Swagar, I had a question for you regarding the first algorithm test, because FDG PET is available easily, but DOTA scan is not available at many centers. So when a patient comes with a suspicion of PNET, that time what should be the first test then after the CT scan?
Ma'am, if the CT scan is done, that is triphasic CT scan, and if the lesion is hypervascular, so we don't advise FDG PET CT in cases which upfront, if we know it is G1, G2 with KI 67 less than 10, FDG PET CT is fruitless. FDG is not going to give much information as compared to a CT scan. Whatever you know from a triphasic CT scan, FDG is not going to add anything else to that. But if the lesion is upfront, we know that is G2 more than 10, K67 or G3, then Ma'am, again, FDG is definitely indicated. FDG shows increased uptake as compared to gallium. FDG is not widely available. Gallium is not widely available. Definitely agree. You can have FDG PET CT scan. It's a whole body scan. So you may detect some other lesions apart from abdomen. You may see lytic skeletal lesions, but I really can't say. I mean, how much FDG is going to help in G1, G2? Not of much help, according to my experience.
I just, yeah.
Dr. Sagat, it doesn't rule out the metastasis at least.
No, it doesn't rule out the meta. Actually, if you are doing FDG PET in G1, G2 less than 20 Ka, 67, I mean, we more often we have to rely on the CT part of the PET rather than PET part of the PET CT.
Yep.
We mostly report the CT part of the PET CT.
Yeah, there won't be any tracer uptake.
Yeah.
Yeah, there won't be any tracer uptake. Yes, right, sir. Exactly.
In the chat box, Dr. Swagar has asked the questions to Dr. Sanjay that if there is a G3 tumor and if it is a resectable tumor, then why don't we go for the surgery? But I think with the increasing development in the imaging modalities, we can find out the G3 lesions with the small size. If there is a small size tumors in the tail of pancreas and histologically if it is G3, I think we can go for surgery, sir. What do you say, sir, Dr. Sanjay Govil, sir?
I mean, see, first of all, if there's a very localized tumor, which is easily resectable and there's been absolutely no metastasis, I think personally, I would not try too hard to get a biopsy on that preoperatively and then make a decision. If it is a small local, you know, I can safely remove it with a distal pancreatectomy or some kind of a limited resection, especially. I'm not going to bother with what the biopsy. I'll wait for the post-resection biopsy. So, you know.
So it means if it is the operable lesion, it should be operated. Doesn't matter the grade.
Yeah, if it is a localized lesion, the thing is, when the chances are that if you've got a more aggressive, particularly non-functioning tumors, you have a more aggressive disease. The chances are that by the time you diagnose it, it's going to be metastatic already. It's the lower grade tumors which you're more likely to pick up, which may be still localized. You know, I mean, even you understand what I'm saying? I mean, low grade tumors may be localized or metastatic, but high grade tumors, most of the time, by the time you diagnose them, are usually already metastatic.
So Vikas, if time permits, there are a few questions. I have 2 or 3 slides. Maybe we can run through them. And
yes, we can run through. We can.
Yeah, I'll just share my screen.
We have time today.
Yeah. Yes. So is the screen visible?
Yes.
Yes.
Okay. So I'll just do a slideshow from the car. So this is a patient who actually came with, again, abdominal symptoms. You can see we did a standard workup. This was followed by a CT scan, and that showed a hypervascular lesion in the head of the pancreas, slightly abutting the vessels, but the vessels were otherwise free. And the initial plan was this was a scan done from elsewhere, was a poor quality scan. And then we repeated our own scan at our hospital. Yeah, and so this was the liver which was seen. And as you see, basically there were 3 lesions, all localized to the left lobe. And this was the main lesion which had a rather difficult location between them, straddling the middle and the left hepatic veins. So my question is to Dr. Govil, Dr. Kantharia, at this stage, how would you approach this particular patient? I mean, he's got synchronous liver metastases with a 2.1 centimeter lesion in the head of the pancreas, which is eminently resectable.
I mean, here's one where I would want to get a biopsy, because either get a biopsy or I would do I would do a PET, a lutetium, a gallium PET, to try and to get the thing. If I get uptake in a gallium PET, especially if I would go ahead and resect.
Right. So actually,
Sir,
we
how
did
will you
do-
jump on the gallium PET? Because we don't know whether it is epithelial tumor or the neuroendocrine. Why will you go for the gallium?
The
No, I
reason
think the chromogranin was raised. So, and the hypervascular lesion exists in the head of the pancreas. So it's fairly convincing that it is indeed a neuroendocrine tumor with synchronous liver metastases.
I mean, I think you're asking
Then we don't need the biopsy
why
now.
not do an FDG PET first, or
Yes.
as opposed to gallium PET? I mean, the way I would look
Yes.
at it is that I'm here. We've got potentially resectable disease, and if at all it is resectable, then you would both from the point of view of deciding towards surgery or future therapeutic options, your gallium PET is going to be the one that's going to give you that information. You know, even if you get an FDG PET positive, all it means is that you're not going to proceed with resection.
Right. So this,
Am I right?
Yeah.
Yeah.
So,
So
I
the
would
patient-
try and get a gallium PET first. You know, I mean,
yes.
So
So this
Swagat want to say something.
DOTA scan, and on the
Dota
DOTA,
PET CT.
the lesions were,
I mean,
there were 3 lesions in the liver, all localized to the left lobe positive, as well as the pancreatic lesion did show an uptake.
it did show uptake on a DOTA scan.
Yes, yes.
Okay, so then I think this is, and there was no disease anywhere else in the bone.
No disease elsewhere. Yes.
So I think, I mean, obviously, I would try to do a resection. And it would probably need, what was the size of the lesion in the head?
It was about
It
2.1
was
to
near the vessel.
2.5. It was.
So it's going to probably require a Whipple in the head, right?
Yes.
Because
Yes.
it was right on the vessel as well.
That's,
So
yes.
yeah, I would do that and try, and I don't think I'd do a left hepatectomy in combination. I would try and do you know, metastectomies if truly all we found on at surgery and intra-op ultrasound for these 3 lesions. Then I would try and do just metastectomies for all of them.
What is the age of the patient, Dr. Saumil?
No, he's 62. He's otherwise fit and healthy. I mean, this patient he came to us, and in this case, actually, I did a left hepatectomy first because, you know, he had this lesion straddling the middle hepatic vein. And I thought before, if he would take time to recover from a Whipple, maybe he would lose the opportunity to have the left hepatectomy. So we actually went ahead, did the left hepatectomy, and came back 2 months later, put him on 2 shots of long-acting octreotide, and then came back and did the Whipple. And it's about 4 years now that he's continuing to do reasonably all right. I mean, he did develop a single lesion in the right lobe, which was ablated in the interval time, but that's what we did. I'll just.
Dr. Swagat want to say something for that?
No, I just wanted to say if I mean FDG PET was had it been done upfront for this case, then and the FDG PET positive, that means the tumor is a high grade tumor. So I mean, in high grade tumor, I really can't. I don't see surgeons are very forthcoming and going operating.
Yes, sir. But the DOTA PET showed uptake.
Yes, sir. No, that time question was whether FDG PET is can it be done? FDG PET can it be done, or gallium to be done, which is to be done? If FDG to be done and if it shows uptake, that means it's a high grade tumor. I mean, low grade tumor doesn't show FDG uptake.
Agreed.
So high grade pancreatic head tumor along with hepatic metastasis, 3 lesions. I mean, sir, you are the best person to comment on that.
No, high grade, we're not going to. If FDG PET showed uptake, we're not going to take this patient for surgery. Yeah.
Okay. Right.
Yeah.
Right.
So I come to another one. This patient had Dr. Chetan has discussed the insulinoma in detail, so I won't go into details of that. This patient again presented with neurohypoglycemic symptoms, had an insulinoma in the tail, which was taken out through a laparoscopic distal pancreatectomy. My question is actually to Dr. Swagat. This is the DOTA scan of the same patient, and it shows uptake in the uncinate process. You did mention in your talk that the uptake in the uncinate process very often is physiological. But we as clinicians, when we see a DOTA scan like this on a patient who comes with an insulinoma and typical symptoms, how do we differentiate? Is it multifocal? What is physiological? What is abnormal? How do we make that decision?
Sir, actually, each and every uptake, if that is pathological, it has to correspond to an anatomical lesion in the CT scan. If there is no corresponding lesion in anatomical lesion to a corresponding CT scan, then probably this is more physiological other than pathological. Here I can see this scan, what you are showing is, this is a non-contrast CT. This is a non-contrast CT.
Yeah, I mean, this is a representative image, but yes.
This is a non-contrast CT. And what I can infer this from this one slice is, uncinate process is not that bulky also.
Okay.
Uncinate process is not that bulky. So I really can't say on these images the abnormal DOTA uptake in that scan, that is whether physiological, pathological, I can't say. Uncinate process doesn't seem to be bulky. This is a non-contrast scan. It should be it has to be a triphasic CT scan to see arterial enhancement, vascular blush. I mean, in such case, I am at crossroad. I am at crossroad.
I want to comment about this because of the physiological uptake of the DOTA in the uncinate process. Some other radio tests we use for the insulinoma, like F-DOPA, because in the F-DOPA there's a mild physiological uptake in the pancreas. When the lesion in the uncinate process, we can pick up in the F-DOPA, and other traces gallium argentine. The F-DOPA and gallium argentine are not available in the every center, but some high institute center, they have gallium argentine and F-DOPA. The F-DOPA is much more helpful for the insulinoma because there is no any physiological uptake in the uncinate process.
Dr. Krishnan, I guess Dr. Somil is asking, in this image, what do you infer in this image?
Yeah, in this image, we can't say because we go for the anatomically base. We see the lesion in the CT base, then we can say this is the case of insulinoma because there is a physiological uptake occur in the gallium uptake occur in the uncinate process. So if lesion is not seen in the CT, so we can't say this is the insulinoma or this is a normal.
No, but is there any specific reason why particularly the uncinate takes up DOTA and not the rest of the pancreas? I mean,
because because gallium DOTA have some receptor more avid, like gallium somato SSTR2, 3, and 5. The uncinate process have more receptor binding, so there's a more physiological uptake in the uncinate process in the gallium DOTA.
Dr. Somil, I need to add one more thing. Again, gallium DOTA physiological uptake in uncinate is least among all the three. DOTA least, then DOTA TET, then DOTA TOC. DOTA TOC is the most physiological uptake.
Okay, and I think we just on time. One final question. This patient actually came with for a regular health check, had something picked up in the tail of his pancreas. He was otherwise completely asymptomatic. You could see there is a particular lesion right at the tail of the pancreas, which got further verified with a DOTA scan. So there was a pickup on the DOTA. He's completely asymptomatic. He's got this 1.5 centimeter lesion in the tail of the pancreas. Should he be offered a resection or could we keep him under observation? Dr. Chetan, Dr. Govil, Pinky.
If it's non-functional, you can keep him under observation, I think.
Close observation, 6 monthly follow-up, I think.
Right.
Yeah.
Initially, at least for 2 years to see the symptoms.
Right. Okay, I think we've just hit 10:30, so I'll hand over to Vikas.
Dr. Govil, I just want to ask if there is a metastatic unresectable tumor. Dr. Basade is not here. I just want to ask if there is a metastatic tumor, it is unresectable tumor. Do we prefer debulking with chemotherapy or only chemotherapy?
No, chemotherapy will depend on the grade. So
Yes.
chemotherapy is usually given for higher grade tumors. So it's a different patient population. If you've got a higher grade tumor, then you're not going to do debulking or any surgical this thing, you know. So I think
Fine.
does that answer your question?
So
Yeah.
theoretically,
Yeah, that's fine.
if I may to add, theoretically, there is a role for debulking. But having said that, nobody would do debulking with availability of Prrt. So
Yeah.
this patient would directly go for Prrt.
So again, it's the same thing. If it is a tumor which is not taking up taking up tracer on DOTA scan, then and it's taking up on FDG PET, then this is a high grade tumor. So if it is, you know, it's a comparison between surgery and DOTA, that is lutetium therapy, these would be the two that you would compare. And therefore, you know, what I mentioned earlier, that adagio con moto, basically proceed slowly. Don't go rushing into doing a debulking, that's exactly what Chetan said. If you're looking at a patient who's got uptake on DOTA, then treat them with DOTA first. Make sure that this is you know, not some rapidly growing or a mixed population tumor and so on, and then decide about surgery. So there's no rush to do surgery. Wouldn't be your first treatment option.
So Sanjay,
yeah,
what he was referring to is debulking surgery, because there are some
debulking would not be your first, would not be your first option. You would always have given you know, other treatments, and especially DOTA, that is
Prrt therapy. Yeah.
But in high grade tumors, you're not going to, neither is going to be effective. Neither PRRT nor surgery is going to be effective in high grade tumors. And those are the patients in whom you will give chemotherapy.
Dr. Swagar, we have read that there are different type of DOTA TOG, DOTA TAG, DOTA NOC. So is there any relevance nowadays with the DOTA NOC? Other variants are useful, or it's just for the theoretical purpose?
It's all theoretical. It's all theoretical.
So we are doing only the DOTA NOC. And what about this expanding pad? Is it available?
Yeah, Extendin also available. Very few centers they are doing Extendin. It's available, yes.
Okay, fine.
So, Swagar sir, I want to ask about some PRRT. Till how much cycle we go for the PRRT therapy, and more we see in the literature there are 30% cases there are stable disease or so progression. So till how much we jump for the actinium therapy, and till what time we wait for the how much activity we go for the lutetium therapy. After that we go for the another therapy.
Actually, see, I mean, this is quite subjective and this is individualized. It cannot be generalized. But one thing is, you can safely go up to 4 cycles lutetium PRRT. You can safely go up, and I am giving between 200 to 250 millicurie to each and every patient with a guarded caution on renal protection. I go slow. I usually give the lowest calculated dose in the first cycle, then I scale up, rather than going on the highest from the first cycle and then scale down. So 3 to 4 cycle, I mean, you have to clinically judge if the patient is stable, the quality of life is maintained. There is no point going beyond 4 cycle if everything is all right. There is no point going. And more than 250 millicurie is also, I mean, clinically irrelevant.
Dr. Swagat, what we do in our practices, we usually give sandwich therapy. Between 2 cycles of PRT, we give a long-standing Sandostatin.
Yes.
Yeah.
Yes.
And we have given maximum 5 times for 5 cycles. After that, I think it doesn't respond, because then it reaches a level where it doesn't help you much.
Sir, in that case, you can switch to alpha PRRT.
Okay.
In that case, if PRRT is still the option, then don't continue with the lutetium PRRT, rather switch to alpha PRRT.
Okay. And when would you think of giving a combination? Do you think combination will help?
Sir, in combination only in those cases which are positive on gallium, positive on FDG with discounted lesions. I mean, there are few lesions positive in gallium, but they are negative in FDG. And there are few lesions positive in FDG and negative in gallium. So in such cases, I mean, 5-FU plus minus capecitabine with PRRT is an option. Yes.
Thank you.
I think we have completed all the topics and all the questions has been tackled from the chat box as well. And now I will invite my backbone of my team, the Bhushan Balgat, to give the concluding remark and make some announcement for the next meeting as well. Dr. Bhushan.
Vikas, I would like to share my screen for a moment.
Dr. Bhushan. Yes.
Hello, am I audible?
Yes.
Yeah. First of all, thank you for all the speakers and all the panelists for giving so much time and making this event successful. We have a next event on the 10th of June 2021 on abdominal wall hernia. It will be the 9th event of TUGS India. Also on the left hand side of the screen, you can see that we have a WhatsApp group. You can use your QR code on either of your phones, Android or iOS, and join the WhatsApp group for further updates. And I would like to thank our the chief coordinator, Dr. Vikas Jain, our co-host, Dr. Saumil Vyas, and the patron, Dr. Kamal Mahawar, for this event. Thank you so much. Good night, all.
Thank you.
Thank you.
Thank you. Thank you.
Thanks.
Thank you.
Thank you.
Yeah. Somil, nice cases.
Thank you. Nice to see you.
Bold enough to do a hepatectomy. I was wondering how that metastasis is done.
Yeah, it was, we had a lot of dilemma, discussed it, and then did that. I think the main thing was it was involving very close to the
Yeah.
middle vein that led to that decision. Right.
So this today's event will be available on the YouTube as well, and I'll inform in the group whenever it will get uploaded. Yeah.
Thank you. Thank you, Chetan.
Thank
Thank you,
Thanks.
Dr.
Bye,
Govil.
bye.
Thank you very
Bye,
much.
Dr.
Bye, sir.
Vikas. Bye.
Thank you,
Have the
everyone.
video all
Thank you so
prepared.
much.
Thanks, Vikas. Bye.
Thank you so much.
Thank you. Bye-bye.